Hello, hello, hello. Welcome back. You are listening to Your Health with Dr. Zach on Nomad Radio. I hope you all had a good week and enjoyed the dreadful weather in place of what should have been summer sun. But you know, it is what it is. We move on. Today should be a very eye-opening show. Yep, pun intended. Because we've got our first guest on the show today, Dr. Ahmed Roble. Who's an ophthalmologist and a trainee eye surgeon. Thank you very much for coming in today. Welcome.
Oh, you're welcome. Thank you. Thanks for having me.
How was your week?
It's good. Good, alhamdulillah.
What have you been up to?
Just work, usual busy work, clinics, theatres.
I can imagine.
Yeah, nothing exciting.
Yeah.
Nothing too exciting.
Nothing too exciting this week. Okay,
Apart from football.
Okay, yeah. I was going to ask you about that. What do you think? Is it coming home?
Definitely it's coming home.
Yeah.
we've got a really, really good chance.
Yeah, no, that's good. That's good. That's good to hear. I think so as well. Sunday should be a very interesting day.
Yeah.
But so we like to start the show off by obviously discussing hot topics and things that are currently on the news and just trying to put the community at ease and trying to dispel some of the myths. But so we'll start off by talking about that. And then the second part of the show, we're going to go into talking about your journey, how you got there,
sure, and
just different aspects of your training. And then we'll talk about some issues that we see regarding the eye in the Somali community and in the BAME community generally.
Yeah.
And then we'll finish up with a Q&A.
Sure.
So yeah, exciting times.
Yeah.
You ready?
Looking forward to it. Yeah.
Good. Okay, amazing. But yeah, so like you said, we were discussing the Euros. You think it's coming home. But I'm not sure whether you saw on social media or just the internet, just generally, Sadiq Khan is offering Euro 2020 final tickets for people that get their first jab.
Really?
Yeah. What do you think about that?
I think it's a good way
Yeah.
to try and encourage people to get their vaccinations. I'm not really sure. I'm not confident how it's going to work. I think there's some segment of the population that's really dug in.
Yeah.
That are completely anti-vaxxers.
Anti-vaxxers, yeah.
Yeah. So they probably won't be convinced.
Mm.
There is the odd people that are kind of 50-50 about it, and you might sway them with a scheme like that.
Yeah.
But I think there is still a significant proportion who are completely against it, who are very suspicious about the vaccine and its long-term effects.
Yeah.
And we see that a lot. I'm sure you've seen that.
100%.
We see that. I see it less in my field.
Yeah.
With speaking to my medical colleagues, they see that a lot, unfortunately. Yeah. But it's worth trying those kind of things. Every little helps, basically.
Yeah.
Whatever way we can encourage people to have their vaccination, the better. I'm all for it.
Yeah, I agree. I 100% agree. I think schemes like that will definitely push people in the right direction and just hopefully end the pandemic sooner than we hope.
Yeah.
So what do you think about the fact that they think the public think that there's this agenda that doctors just want them to be vaccinated? They don't care. It's just want to push it across. What do you think about that?
Yeah. So I think it's two things. I think it's partly historical. It goes back to when certain vaccines were not very popular. For example, the MMR debacle. The main thing, the key fundamental thing about our field, medicine, is based on trust.
Mm-hmm.
So it has to be that the public trust the medical profession.
Yeah.
The MMR vaccine, if you study the history of the medical profession here in this country, the MMR vaccine really kind of dented that trust.
Yeah.
There's still the uptake of the MMR vaccine is very low.
Yeah.
So a lot of people are already skeptical about vaccines based on shoddy research, based on conspiracy theories, based on a host of factors.
Yeah.
So with that kind of fertile background, the COVID vaccine, especially because it's a fairly new vaccine that's been done in such a short, remarkable period of time, you're going to get people that are suspicious of it.
100%, yeah.
And it's going to be very difficult to convince them.
Yeah.
I think a lot of people won't take up the vaccine just simply because they will not get over that kind of Rubicon where they're going to go and cross that threshold.
Yeah.
It's really, really tricky.
Okay.
Some people who are actually, I've seen patients who are really unwell that are high risk of contracting COVID, still refuse.
Still in denial,
So it's based on trust, it's based on fear, and also depending on which demographic you look at, certain ethnic communities already have kind of certain amount of mistrust about Western medicine and what doctors might do to your body, what medications might do to your body.
Yeah.
If you throw in that already hostile suspicion, then you're going to get patients that are where the uptake of the vaccine is going to be very low. And we see it in our own community. I see it in my own family members.
Yeah, I agree.
I'm sure you have.
Yeah.
So that's an endemic problem. That's not going to go away, I'm afraid.
And what do you think we can do as Somali healthcare professionals to, bridge that gap of distrust and try to push people into the right direction? What can we do to kind of make them trust us more and just show them that, we're not trying to force the vaccine onto anyone, because as doctors, obviously, we believe in autonomy. Yeah. So it's people's right to make their own decision. Yeah. So what do you think that we can do?
I think the best thing, by far the most proven effective strategy, is what we're doing now. So raising awareness. A lot of people don't know much about the vaccine. Yeah. If you actually sit down with them, you tell them what the vaccine is, what a brief summary of what the trials were, how the risk is so low. Yeah. If you explain that, then you might get people on board. Yeah. So I think raising awareness is key. Yeah. A lot of people just don't know the vaccine, and there's a disproportionate amount of fear based on to what the actual risk is. The risk is really low if you take the vaccine. Yeah. That it's going to significantly harm you. Yeah. So awareness is key. So definitely the more we raise awareness, like what this show is doing, what other Somali community members are doing, if they can go out and do grassroots campaigning. 100%, mosques is a great way. So holding seminars or talks in mosques is a great way now that mosques are reopened. Yeah. So whatever avenue that we can use to raise awareness, I think we should. Yeah. Starts with your own family and you just extend it. Yeah, definitely. It starts at home. Yeah, I agree with you. So in terms of obviously COVID, how have you found that COVID has affected your work? So COVID has been very challenging in a surgical specialty like mine, because at the end of the day we're surgeons. Yeah. So it's basically, when it first started, the initial lockdown, there was no operating at all. Wow. So this started, I think, was it March last year when the lockdown started? So from March till I think September, there was no surgery. Yeah. The only surgery that was happening was emergency ophthalmic eye surgery, which is quite rare to get that. And emergency, even then, was kind of codified into a strict criteria where you had to prove that the patient was at significant risk of immediate visual loss, then you can operate. For example, if they had a very severe eye infection where you had to go in and remove kind of like infection from the eye, stuff like that, which is quite rare. But all the elective stuff, which ophthalmology, majority, 90% of our work is elective surgery, was all stopped. Cancelled. Yeah. So training, there was no surgical training for like a significant period of time. Yeah. So that had a personal impact in terms of, as you know, when you're training, you kind of have to meet competencies to kind of get signed off and so forth. So it slowed everything down. And in terms of the clinic capacity, we had to stop. So we could only see patients where there was immediate threat to sight loss. All the actual elective clinics also stopped. Yeah. So we basically converted to being a basically calling patients. Yeah. We basically did reception work. Oh wow. Like clerical admin work. And obviously your reach when you're calling patients is going to be completely different to actually seeing them in person, the amount of investigations that you can do when they come in. Absolutely. How did you find that affected you in terms of in a professional capacity? And even patients as well, how did you that affect the patients? So it was quite daunting and scary, because when you're training, you don't want to make a mistake at the end of the day. You don't want to be responsible for someone loses their sight or someone coming to harm potentially. And you're always aware about the medical, legal kind of ramifications of whatever you do, because the buck stops with you. So we kind of pushed the group that we pushed our department to issue guidelines and protocols. So if a patient had X, Y, and Z, this condition, and they weren't seen for a period of time, how could we extend it by? So at least we had protection, legal protection. So we ensured that happened. And I would, essentially when I was calling patients, most patients are going to tell you their vision's blurred. Yeah. So it's very difficult to kind of judge over the phone 100%, how bad it is. Yeah. Because it could be a simple watery eye that can be blurred vision to something more serious like a bad infection or whatever. Yeah. So it's quite tricky. So patients that I was really, really worried about, I would tend to break the rules a little bit. I would actually see those patients. I would call them in because I felt that I had a obligation to ensure patient care. At the end of the day, that patients didn't come to harm. Yeah. And I would do it in the best possible way that I could. That met all the hospital COVID, social distancing, all the requirements. That's good. So patients I was worried about, I managed to find a way to see them. Yeah. And I think at the end of the day, you owe a duty of care to patients. 100%, yeah. Obviously without harming others. Yeah. But your first duty of care is to patients. Yeah. I think it's definitely better to be safe than sorry. Yeah, absolutely. 100%. Absolutely, yeah. Okay. Yeah.
And in terms of, you said your training stopped. So obviously, how did that affect you in a personal capacity? Obviously.
So yeah, I mean, it was really, really tough time because it was so frustrating. We couldn't, the thing that you love doing, you couldn't do it. All of a sudden stopped.
Yeah.
And you couldn't progress in the stages of training because you had to get certain things, you had to be supervised that you could actually do, you're competent enough to do these things.
Yeah.
So it kind of set back training.
Yeah.
Alhamdulillah, for me, it didn't really have a good impact because I was fairly senior enough by then.
Good,
I was a registrar level. But for my junior colleagues, they may have to do an additional 6 months.
Yeah.
Or additional period of time to kind of compensate for the time that they lost.
Yeah.
The other thing it had also, it cancelled exams, all the fellowship exams.
Yeah.
Yeah, were all stopped.
Wow.
So that kind of set us back. Alhamdulillah, I managed to catch up and get through them. But some people didn't. So it had a huge impact on training. Yeah. It was really, really difficult for all surgical specialties. Yeah.
Nice.
It set some trainees, registrars back by a year.
Yeah.
Or they have to do an additional year of training.
Yeah. That's definitely a shame to hear because obviously the training already is quite extensive. So I think an additional year, I think will just definitely have some very knock-on effect on people's mental health, especially.
Yeah, definitely.
And okay, in terms of, inshallah, once this pandemic ends, what do you think is going to happen in terms of, obviously, in your field, the type of patients that you're going to be seeing or the type of cases? What kind of effect do you think COVID is going to have on your field post-pandemic?
So I think two things. Clinically, and the logistics of managing eye departments will change post-COVID completely. Already the NHS had a severe backlog, as you know. COVID has just kind of basically exacerbated that so much. So what we're seeing now is that we're unable to provide timely care to patients simply because we cannot get through the number of patients. There's just not enough resources, not enough doctors, not enough nurses, not enough staff to kind of see everyone. Yeah. So there are documented in the literature of patients who've come to harm from long waiting lists. Wow. So number one is going to be long waiting lists and access to care, access to timely surgery. Yeah. So some patients will undoubtedly come to harm because of the extension that COVID has done to NHS resources. The other thing is COVID has impacted on the clinical scenarios that we see. Yeah. So I've seen a lot of weird stuff that we think it's COVID, but we haven't quite proven it. Yeah. Because we haven't been able to get a sample. Yeah. So kind of like weird eye inflammation. Yeah. I mean, I saw a guy just a couple of days ago who had some weird kind of optic nerve problem. But I'm pretty sure it was COVID related because it happened, I think a few days after he got COVID infection. Yeah. But we can't prove it.
There's not enough research yet, is there?
Way down the line, 20, 30 years down the line, when there's enough research,
you look back and think
we're going to find
that's what it was.
Yeah. And especially in my field, as a kind of like doing the cornea front of the eye stuff, there's a few cases in the literature about corneal transplants that have rejected post-COVID COVID infection that failed as a result of COVID. Okay. And they've actually taken samples from the eye and it had COVID mRNA. Now we don't know whether that is post-COVID, actually getting COVID, or post-jab. We don't really know. Okay. But COVID is going to do kind of weird stuff. Yeah. Most of it's transient, 99% of it. Patients will get better. So it's not significant long-term harm. Yeah. But it has changed our specialty in terms of the logistical front and the clinical cases that we see on a daily basis. Okay.
No, that's definitely very interesting in terms of, especially with the rejection of the cornea transplant and
there's a couple of cases. I think one was at Moorfields where one patient's cornea rejected. Cornea had been stable, the graft rejected, and they did a PCR and it was PCR positive. COVID. Okay. We don't know how. We don't know whether this will impact every patient who gets COVID who's had a corneal transplant. We just don't know. And I think we're going to find out decades down the line. We're going to find out exactly the exact impact in our field. Yeah,
no, that makes sense. And in terms of, so what you were doing during that pandemic, obviously you were running your normal clinic, but did you ever have the chance to actually go to like ICU or like were you redeployed?
Yeah. That was quite a scary period for ophthalmologists, really. I can imagine. Because when you've been doing eyes for so long, you kind of forget the medical stuff. Yeah. So they redeployed us actually. Yeah. We got redeployed to ITU and the medical wards. Wow. So we were redeployed for 3 weeks. This was at the height of the pandemic when it started. so I was doing a mixture of ITU and hospital wards.
Yeah.
Alhamdulillah, I mean, I was really well supported because
Yeah.
you're completely out of your depth, man.
Yeah.
You really, really don't know what you're doing.
Yeah.
So they didn't make us examine patients medically because that would be inappropriate. We wouldn't know what we'd be doing.
100%, yeah.
So we had a lot of support. There was a lot of large medical team.
That's good to hear.
So it was a scary time.
Yeah.
It was a scary time. But we got through it with support.
Yeah.
In fact, to be honest, they organised it quite well actually. The NHS was very good
at
managing that kind of anticipating that surge and making sure the hospitals don't overrun.
No, that's very good.
In my experience anyway, when I was in Brighton.
And in terms of, so what's your, like, what message would you give to people that don't believe, obviously, because if you are on ICU, what message would you give to people that just don't believe this COVID's a thing, or that don't think they need the vaccine, or think they're completely safe? So what's your final message to them?
So it's really difficult to convince someone who's kind of so dug in. COVID is real. As someone who's been in intensive care and as someone who's had actually family members die from COVID, it's a real infection. We can isolate the infection. We can take a swab. I don't understand the discrepancy between that average person who maybe doesn't believe in COVID may go and see their GP and they trust their GP if their GP makes a diagnosis. But it's real and it's a significant. It's not a normal flu. It's a severe, serious condition. If you're at risk, can harm you, and the best way to protect yourself is to get vaccinated.
Brilliant. But yeah, I'm sure there's going to be a lot of people today that are listening in that will benefit from what you have to say. So yeah, let's focus on you now. So just talk to me. Let's start at the very beginning. How did you get to where you are today?
So I think I was always interested in, I kind of like biology when I was in school, one of my favourite subjects. And I remember watching a documentary by a guy called Henry Marsh, who's a famous British neurosurgeon. This was when I was a kid. He used to work at St. George's, and he used to do kind of like brain surgery awake. And I used to think, wow, that's amazing stuff. So that was kind of like my first initial interest. So I kind of always knew I wanted to do kind of sciencey stuff. But I didn't really know exactly what field and whether I wanted to do medicine or not. So I did well at school, GCSEs, A-levels, I did fairly well. Did a science degree because even then I wasn't too sure what I was going to do. But I had a Somali friend actually, Saeed Abdullah, who's in Saudi Arabia now, excellent physician. He was a chest doctor.
Wow.
North Middlesex Hospital. He was really good, and he used to work at Whipps Cross as well. So I used to be with him, and I had another friend who was an ophthalmologist, a Libyan consultant, who I used to play football with.
Oh, wow.
I used to train twice a week. So I used to kind of shadow him. I'd be with him in clinic, and I really liked it. And it basically just led on from there. So then I thought, do medicine. And during medical school, I just wanted to get through it, really. I wasn't really thinking too far ahead. Didn't really felt that I kind of belonged, if you like. Which I'm sure a lot of young Somali students now feel the same way.
100%.
So it was just a case of just getting through. And when I got through, during my foundation training, I kind of realised, well, my first on-call, medical on-call, I realised that wasn't for me. Because it was just so intense. And it was really, really intense. It was non-stop, the beep going off, and I was like, I can't do this for the rest of my life. So that was kind of put to the back burner, no go. And then I did general surgery, and I remember my first theatre session was removing gallbladders, and we had a large bowel. Can't remember exactly what it was, but basically removing parts of the large bowel. And I was like, this is just too much. It's not clean enough for me.
It's too gory.
Yeah, it's too gory. So I thought general surgery is not for me. So I finished my first year F1 training, still then not exactly knowing what I wanted to do. And I went back to my friend of mine, Libyan consultant, and he was working as a consultant where I was doing my F2 in Reading, Royal Berkshire Hospital in Reading. So I shadowed him for 2 weeks, because at the beginning of F2 or F1, you can kind of like do a taster week in a specialty that you're kind of interested in. So I did that. So I did ophthalmology, and I was like, wow, this is for me. Because it had a good work-life balance. There was no impatience. Importantly for me, I didn't have to deal with people terminally ill or dying around me, which I felt that I couldn't deal with. There was no inpatient list, so I didn't have a ward. It was all clinic and theatres. surgery was quite micro level,
Yeah.
which I really, really enjoyed.
Yeah.
And there was a lot of technological advancement in eye surgery, that stuff that we can treat now that 20 years ago patients were going blind.
I don't know.
And the other amazing thing was that you can do a 20-minute procedure and someone could see a few hours later.
Yeah.
So it's instant.
Wow.
You see your results instantly.
Yeah.
So
How does that make you feel?
Cool. Oh, it's cool, man.
Yeah, I can imagine.
I can't. I've been in Hounslow now in Ashford Hospital, and I remember operating on an elderly Somali lady who had a very bad advanced cataract, basically a white cataract, couldn't see much.
Yeah.
Alhamdulillah, surgery went well. She came to the clinic a week later. So she went from not seeing much at all, so kind of like hand movements vision, to 6'9", driving better than driving standard vision.
Wow.
And that is just from a 20-minute op.
Yeah.
And you can imagine if you can extend that to back home in Somalia, East Africa, the amount of elderly people that just go...
They'll benefit from that.
That go blind from a simple cataract that you can remove in 20 minutes.
Yeah.
It's one of the most rewarding things you can do, man.
Yeah.
And honestly, it's an amazing experience.
I can imagine.
Yeah.
And in terms of like, obviously growing up, what sort of aspirations did you have? Like, did you always want to be a doctor?
So I think I always wanted to do well academically.
Yeah.
I didn't know whether I wanted to be a doctor.
Yeah.
Partly because my older brothers and my sister went to uni, so they kind of all did relatively well academically. So I was just kind of in that environment, really.
Yeah.
So I knew I wanted to do well
Yeah.
in my GCSEs and my A-levels.
Yeah.
I think it was really towards when I was doing my biomed degree that I definitely decided that I wanted to do medicine.
That's it, yeah.
But I think the key thing is just do well at your education, wherever you are, whatever grade you are, whatever stage you're at, just get the best out of yourself.
100%.
It doesn't really matter. Don't think too much about what you want to do in 5-10 years down the line.
Yeah.
Of course, it's good to make future plans, but focus on the now and just get the best of your ability now. So if you have a task ahead of you, do it to the best of your ability.
That's some very good advice. You all heard that. Just focus on the task ahead of you and just don't think too much about it. And if someone told you when you were like 14, 15 that you're going to be operating on eyes at this age, would you believe them?
So when I was 14, my main aim in life was to be a footballer for Barcelona when I was 14. I clearly did not have the skills to that. But no, I definitely will not believe it, man.
Yeah.
There's no way.
Yeah.
14-year-old kid from Fulham. No way.
Yeah.
I would have thought that I'd be here now.
So you grew up in Fulham, West London?
I grew up Fulham. Initially lived in Hammersmith, just down the road from me, actually. Ravenscourt Park.
Yeah.
Then moved to Fulham. But I would have never thought it that I would be here now, where I am now. So no. So I think if you have a goal, just if you stick to it, it's doable. It's doable for anyone. Honestly, I'm living proof that you can get through medical school and be a year away from being a consultant. It's all doable, definitely.
It's amazing, mashallah.
It's nothing special, honestly. It's just hard work, a bit of hard work, a bit of studying, and a bit of sacrifice.
Yeah.
That's it.
And in terms of, obviously, Fulham, especially back then, probably wasn't the nicest area.
It wasn't too bad, actually. It wasn't too bad.
What sort of struggles did you have, obviously, growing up that could have potentially stopped you from pursuing your dreams, or the sort of, I don't know, traps that, for example, your peers or your cohort were falling into?
So, I mean, I think any young boy or young girl going to a comprehensive in London is going to be exposed to certain challenges. The key thing is just to have a good crowd around you, have a good bunch of friends around you.
Yeah.
Growing up, I think when I was in year 9, like starting year 10, I got into kind of like a bad crowd at that time. And I could have gone off the rails easily. And I think if you have a good family support and structure around you, that can kind of pull you back. So luckily I did. Yeah. But the key thing I would say is just having good friends around you is really, really crucial. And listen to advice. Yeah. I know that when you're that young, it just seems so distant.
Yeah. You think you know everything.
You think you know everything. Yeah. Listen to that advice, man.
100%.
Definitely. Yeah. If you listen to that advice, keep your head down.
Yeah.
Then, I mean, there's a lot of Somali kids, mashallah, alhamdulillah. We come from a community where our youth are really talented, man. Yeah. They're really, really talented. They've got huge amounts of potential. Yeah. Not just in academically, but in sports. You see a lot of Somali boys who are excellent at football that can really make it at top level. Yeah. And it's just that mental support that they need at that 100%. Young age is crucial. And if they can get that, they can do whatever. Yeah. Literally, the sky's the limit.
I agree. I agree with you 100%. And so what made you pick, so you told me what made you pick ophthalmology over everything else. But in terms of your actual specialty, what do you enjoy the most about it?
The surgery, by far.
Yeah.
Yeah, by far, by a distance.
Yeah.
The surgery, it's because it's so varied.
Yeah.
I mean, when people think of the eye, they just think of one organ, but the eye is incredibly complex.
Yeah.
Kind of like an optical structure. So there's some eye surgeons that kind of sub-specialize. They only do one part of the eye, which sounds weird. So what I'm working towards is doing corneal transplantation surgery.
Yeah.
And that is kind of like a niche within ophthalmology.
And for those that don't know what corneal transplantation is.
Yeah, so the cornea is the front window of the eye, the clear, see-through structure. So that's the part of the eye that's most important basically for bending light into the back of the eye so you can focus and see the image.
Yeah.
So if your cornea doesn't work, you can't see properly.
Yeah.
So there's a lot of conditions now that we can treat that 15, 20 years ago that we couldn't treat. So learning about transplantation surgery is just an amazing experience. I can't really put it into words.
Yeah.
We had a case, today's Thursday, right? We had a case yesterday where we could do quite micro level surgery where you kind of transplant a 70 microns thick layer of corneal tissue into the back of the eye, which couldn't be done about 20 years ago. Yeah. But with modern techniques and modern technology, there's a lot of stuff you can do to improve sight.
Yeah.
And I'm hoping, inshallah, in the future, if things work out for me, that I can introduce that in Somalia, inshallah.
Yeah.
Because there's a lot of people that have corneal disease in Somalia.
Yeah. No, definitely. I think that's a very amazing goal to have, especially just the fact that you take all the medical advancements here, you learn them, study them, and then just take them back home. I think will make a very, very, very significant.
For example, Somalia now has no eye bank, so there's no official. If you needed a corneal transplant or another part of the eye transplant, you'd have to go abroad. Yeah. So it's things that can be done with the right will and obviously the right support, the right team around you. Yeah. But I'm hoping, inshallah, post consultancy that I can kind of kickstart off.
Definitely.
It's over a centimetre. So you're operating within that kind of narrow, confined area. So you have to have steady hands. Yeah. You have to have really, really steady hands.
I can imagine,
so when I first started, actually, I had a bit of a tremor, natural anxiety. But that kind of settles the more cases you do. The more confident you get, the more you get into it, you get into the rhythm. Cataract surgery, same.
What do you least enjoy about your specialty?
I would say the clinic load in the NHS is huge. Yeah. Now, ophthalmology, it's the most outpatient-led specialty of all of medicine. Yeah. So the clinics can be huge. You see a huge number of patients. And that can be really, really stressful. I was at clinic this morning, which was really, really busy in terms of just the number of patients. Yeah. And we're all living longer, aging population, so everyone gets cataract. Yeah. Everyone has pretty much some level of glaucoma. Yeah. Majority of people have diabetes. There's some bits of diabetes in the eye. So the longer we're living, the more eye problems we're seeing. Yeah. So it's the workload, definitely the clinic workload. I don't enjoy that.
What did you do?
Yeah, so I think the trickiest case was a lady who had a complex cataract. So she had quite a hard rock cataract with zonules. So the way the cataracts work is it's like a lens, and it's your natural lens that becomes opaque with age, and that's what we call a cataract. And it's these little fibers, almost kind of like cranes on a building site. They kind of hold the bag in place in front of the eye. Yeah. So she had weak zonules. Oh, wow. So the bag was a bit floppy. Yeah. So that was really, I think that's probably the most challenging case that I've done. She had quite a narrow, very smaller eye than usual. Yeah. So it was quite tricky to get through that. Yeah. But alhamdulillah, I did. The key thing with that is that, like in life, in any advice, really prepare yourself. Yeah. The more you practice, the more you can do simulation now. So a lot of deaneries, a lot of hospitals have what we call eye size simulation, which is basically going on a surgical simulator, a bit like a plane pilot simulator, flight simulator. Yeah. You can do that for eyes. So I used to just put the hours in that. And you can set a mode to advanced cases, complex cases. Yeah. So I would do hours and hours of that, and it just makes the experience much more bearable. Wow. So with practice, it's doable.
Okay. Amazing. Thank you very much for that. Yeah, so we just discussed his pathway and what it took for him to get to where he is now. And mashallah, it's a very vigorous and long training pathway. What advice do you have for doctors, aspiring doctors, or just training doctors like myself? Because obviously compared to you, I've been a doctor for 10 seconds. So yeah,
you'll catch up. I'm sure you'll catch up. You're just starting your journey. I think the key thing is finding someone that can advise you of the pathway, because it even within medicine, once you finish medical school, it's just kind of the beginning of a long career. So finding out what you want to do, and finding out how to navigate the system is crucial. I always make myself available to young Somalis who are doing medicine or in medical school or post-medical school who are unsure about their career and how the application systems work. So I'm always available if they want to contact me for advice. Yeah. So when I was going through it, my friends who were a couple of years above me in med school, non-Somali, 2 of them became ophthalmologists. They really helped me with the application, and they helped me navigate through the system. So I think it's crucial to have someone who's been there, done it, basically. Yeah, that's really good. Important. And to have a mentor that advises you. Yeah,
I think it's that mantra, obviously. See one, do one.
Yeah, exactly. So, the old adage
definitely.
Mantra. Yeah.
And obviously, this part of the show, obviously, we like to focus a bit more on the community and just try to give back in terms of what we've learned, what advice we have in terms of their health, what they can do to improve it, what they can do to avoid certain things. So obviously today we'll be focusing obviously on the eyes and conditions and the lifestyle that might affect the eye in a very bad way. But so obviously, mashallah, obviously the number of Somalis that obviously work in healthcare now is continuously rising, and you must be seeing like more and more doctors that are from Somali background, much more in comparison to when you first started training. Do you feel like the divide between the Somali community and healthcare providers is reduced by this, or?
I think it can be. Yeah. It's difficult to tell at the moment because we don't really have any evidence how effective we are at our campaigning and our attempts to raise awareness. Yeah. So we don't really know at the moment. But the only thing we can do is keep going. Yeah. So the Somali community has got unique challenges in not just in ophthalmology, but just basic general healthcare and access to medicine.
I agree.
And if you just take a microcosm, if you just take your family or my family or my mum's experience of the NHS or your mother's experience, I think every person listening to this show can relate if they've taken their mum to the GP.
Oh yeah, definitely.
The ability or the challenges faced in trying to access
playing that translator role.
Yeah, definitely. So you can imagine people that lack the understanding of how healthcare is how healthcare works, and how you can take advantage of healthcare to your own benefit. They're going to struggle in a system like that. Yeah, definitely. And that happens in every minority ethnic community. If you look back in history, it happened to people that came from the Caribbean. It happened to people that came from the Indian subcontinent. Yeah. And it's something that gets better over multiple generations. So our generation will suffer it less. Our children's generation will suffer it less. Yeah. So in ophthalmology, there is a huge pandemic of people that have glaucoma. Yeah. So glaucoma, just to summarize, is basically a condition in which you lose your peripheral field of vision, basically, over time, slowly, till you end up with a tunnel vision. Yeah. And then that bit in the middle eventually goes. Yeah. Now, glaucoma is a silent disease. You won't know it unless you're tested for it. You won't experience any symptoms till it's too late, till you've got that tunnel vision. And there's a lot of glaucoma. The incidence of glaucoma is higher amongst Africans. Yeah. If you compare it to the Caucasian population. So there's a lot of Somalis that have glaucoma, probably undiagnosed. Yeah. That need to see the opticians, that should have a visual field test. Yeah. That are just simply not aware. So that's just one condition.
How often would you say they should go to the opticians?
So if you have a family history of glaucoma, if you have a first degree relative, so a parent or a sibling, then you should see your optician once a year. Yeah. And you should have a pressure check. Someone checks the pressure in your eye. Yeah. And you should have a visual field test. Yeah. Once a year. Yeah. Definitely, because you're at high risk. Yeah. Statistically, the risk is at least 2 to 3-fold risk of developing glaucoma if you have a first degree relative that has it.
And
go on.
I was going to say, what sort of actions can we take as a community to obviously reduce our risk of getting glaucoma?
So the number one, by far the most important thing is detecting it. Because once you detect it and you diagnose it early, you can treat it and it stops the progression basically of the condition. So glaucoma is one of those weird conditions where once you get it, you can't reverse it. It's an irreversible condition. So it's almost like once the train's set off, it's kind of set off. What we don't want is the train to run at 100 miles per hour
100%.
and you lose your sight within your adult lifetime. We want that train to be really, really slow for you to be able to visually function as normal late into your later parts of your life. So early detection is important, which is why going to the optician, getting your pressure checked, having a visual field test, they're usually very good at picking up early glaucoma. Or if your pressure is a bit high, they'll refer you to the eye clinic. So that's really important. So raising awareness of that this condition exists, you have it, you might not be aware of it. It's really, really important. And there's other conditions like diabetes. Diabetes is high anyway amongst the ethnic population. 100%. If you look from the Indian subcontinent demographic, Africans.
Sorry, what sort of ages does glaucoma affect? Just so.
So going back to glaucoma usually it's a disease later on in life. So it usually starts off in your 40s, 50s, 60s. In research has shown that in Africans, it starts off younger age. So usually in the 30s and 40s.
Okay.
So and it tends to be a bit more aggressive in African patients. It tends to grow much quicker. So I can't stress enough, if you've got a family history or if you know anyone in your family used eye drops to manage their pressure, get your eyes checked out once a year by your optician.
Definitely. You guys all heard that. Definitely just go. It's one of those things, like, better to be safe than sorry. You go to the opticians, probably take an hour of your day, maybe.
Definitely.
Get it checked out, and then you can find out whether obviously you've got glaucoma or not.
And the other key thing is that if it's detected early and treated, you can live a normal life with it. And it never causes you problems.
I think your vision is one of those things that you don't want to sort of play around with. So.
And glaucoma, just as a one last thing, why it's really important, not just in terms of vision, glaucoma is one of those things that can affect your ability to drive. Okay. So there's certain standards set out by the DVLA that if you're a glaucoma patient, depending on how bad your glaucoma is, some people lose their license. So it's one of those things, if your job depends on it, for example, if you're a swine professional where your job is driving and you've got a family history of glaucoma, get your eyes checked out because you might lose your license as a result of it if you don't.
You heard it here, guys. You heard it. So you were moving on to diabetes. Obviously, diabetes is a very, very big topic, especially in the Somali community and all ethnic minority communities mainly. Can you just briefly explain, obviously, how having a high blood sugar can eventually lead to problems with your vision?
Yeah, so diabetes tends to cause a lot of problems with multiple organs, not just the eye. But in terms of the eye, at a micro level, it clogs up your blood vessels, essentially. And it leads to your retina, especially the thin film at the back of the eye that allows you to see, that can die away. And if that dies away, the body tries to make new blood vessels to try and supply blood, oxygen and nutrients to that retinal tissue. And these new vessels are quite frail. They tend to bleed easily, so they can cause bleeding in the back of the eye. They can cause bleeding and vessel growth in front of the eye. That can cause the pressure to go up. And you can develop glaucoma as a result of that, going back to glaucoma. So diabetes really, when it gets into the eye at that level, is what we call end-stage diabetes. And it can cause scarring and visual loss, blinding. And if you are diabetic, it's the fundamental thing in how you want to save your sight is to manage your sugar levels. So to optimize your sugar control is the best way to treat it. Once it starts bleeding in the eye, we can do certain things to try and help it, but ultimately the key thing that helps your eye is your overall sugar control, and that helps other things as well: your heart, your brain, your kidneys, whatever. 100%. Helps multiple other organs. And it's a big epidemic, really, because there's type 1 diabetes, as you know. There's a huge number of people with type 1 diabetes, young people. Type 2 is much more common in our community. It's quite rare to see type 1.
Why do you think that is?
Genetics background. I think there's much more obesity in our community. There's much more hypertension, high blood pressure, high cholesterol levels. And these are all the things that make you much more susceptible to developing type 2 diabetes. Type 1, I'm pretty sure it's just the genetics. It's much more common in the Caucasian population if you compare it to ethnic minorities. That's to do with genetics, food consumption, the type of food that we eat. So whether you're type 1 or type 2, still the message is the same.
Yeah.
So manage your sugar levels appropriately. If you need to see your doctors, make sure you see your doctors. Don't miss clinic appointments.
Yeah.
I remember a case. I had a Somali lady a year ago when I was a registrar who had really bad diabetes, and she would just never turn up to the eye clinic appointments.
Yeah.
And even though I'd sat down with her, kind of in a busy clinic, and I'd give up my time to speak to her in my limited Somali, if you like.
Yeah.
I'd explain to her husband, I'd explain to her, like, your diabetes is really bad. You really need to manage your sugar levels.
Yeah.
You're having these eye problems. There's a potential that you could lose your sight.
Yeah.
And she's fairly young. She was in her 40s. She wasn't kind of like an 80-year-old elderly person. She's quite young. And so the take-home message is manage your sugar levels properly and follow advice.
100%.
Yeah, compliance is key.
Yeah.
Be compliant with what your doctors have told you.
Yeah, 100%. And in terms of, obviously, I think high blood pressure is definitely another thing that affects the Somali community and all ethnic minority communities the same. How does that affect the eye?
High blood pressure is similar to diabetes. How it affects the eye. It can cause bleeding if the blood pressure is too high. And it can cause the optic nerves to swell up. Yeah. The bleeding can lead to bad new vessels growing, and these can cause further bleeding. So it can damage the retina through hemorrhage, through a bleed inside the eye. And if your blood pressure is that bad where it's causing bleeding in your eye, then it's really, really bad. It's what some medics may call it malignant high blood pressure. And the key thing is when we see it in the eye clinic, we tend to refer them on promptly to the medical doctors to treat it. So if someone's got bleeding in their eye as a result of high blood pressure, it means that their kidneys are probably not working properly. The blood pressure's got to their kidneys, it's got to their brain and so forth. Okay. So again, similar to diabetes, is optimizing your blood pressure. If you smoke, don't. That's going to make your blood pressure worse. Diet control, exercise we know regulates blood pressure much better. And helps to lower blood pressure. 100%. So regular exercise or regular any form of kind of mobility, any form of exercises. It doesn't have to be kind of an hour session at the gym. But even gentle exercises is known, proven. The evidence shows has a positive effect on blood pressure.
100%.
Yeah.
Okay. And in terms of eye issues in the Somali community, other than obviously glaucoma, the diabetic retinopathy, and even like high blood pressure, what other sort of issues do you see coming into your clinic? Yeah, so it's been an eye-opener for me because in my training so far, I've been in areas like Brighton and Hastings, where there's hardly any Somali community. But coming now to West London, where I work now, I've seen a number of cases of young Somalis in their teenage to mid-20s to late 20s. In a condition where the cornea, the front window of the eye, begins progressively to thin out. And that can cause visual blurring. And that is linked to teenagers or kids when they're very young who have hay fever and asthma, who especially get seasonal hay fever where they're rubbing their eyes a lot because they get itchy eyes. So they end up with this condition called keratoconus. And some of them are not even aware till they go and see their optician. And usually they'll see their optician when their vision is blurred. But the thing with the keratoconus is that it doesn't affect both eyes equally. So one eye could be relatively spared, and your brain basically just adapts and uses that eye to form your image. You just compensate basically. And you're not aware of it. You're not aware of your bad eye, if you like, till you go and see the optician, and the optician covers your good eye and forces you to read the chart with the bad eye. Then you realize how bad the vision is. So this condition is really important that we diagnose it and treat it early on because we can prevent it progressing. And we can prevent it with the patient ending up with a corneal transplant in the head, which is big surgery. So I've seen a few cases in the Somali community in West London now. So I think raising awareness of that is really, really crucial. That if, as a parent, if you see your son or daughter rubbing their eyes a lot, especially when they're young, in their early teenage years, you know, the old adage, your parents saying, don't rub your eyes. It's actually true, man. I never used to believe it, but it's actually true. Don't rub your eyes when you're young. And if we can get that message across, if you see your child doing it, take them to the opticians. Get them a refraction where they test their prescription, because that will show up early signs of keratoconus. And they can be referred on. The sooner they're referred on, the sooner they're treated,
the better the outcomes are.
Yeah.
So that's really the key take-home message, because it's treatable at the end of the day.
Yeah.
A lot of these conditions that we talked about, with early detection, it's treatable and everyone can have a normal life. Really.
I think definitely, I agree with you. I think that's definitely, hopefully, if there's anything that you're going to take home from today, it's definitely just
early detection.
Yeah. Go to your opticians, book an appointment. Yeah. It will not take time out of your week or your day. In the long run, it's definitely, a very good investment of your time.
It's the best form of medicine.
Yeah.
Prevention.
100%,
yeah.
I agree with you. And what's next for you? Like, what's the plan?
England game on Sunday.
Yeah. Yep.
Hopefully we'll win. Sure. Long term, I mean, I'm a year away from finishing training and becoming a consultant. I've got probably do a fellowship, external fellowship, to kind of hone my skills in corneal transplantation surgery. Yeah. And then apply for consultant jobs. I'm not too sure at the moment. I'll go whoever's willing to have me as a consultant.
Plans to go back home eventually.
Yeah, inshallah, if it's safe enough. I mean, there's a few projects I've got lined up, potentially which I want to set up.
Yeah.
So inshallah, long term, if things are stable, ophthalmology is kind of niche. There's not many eye doctors. Yeah. There's not much eye care in Somalia, in the whole of Africa, really. Yeah. I think there was two ophthalmologists.
Yeah.
Population, I think that's close to 9 million.
Wow.
So that's the level that we're talking about.
Wow.
So it's huge demand.
Yeah.
Yeah.
That's amazing. Obviously, best of luck to you.
Thank you.
Inshallah, you go back home, change the Somali healthcare, change ophthalmology back home.
I'll do my best.
Where can everyone find you?
I mean, I'm happy to give my email address out. I'm on Twitter.
Yeah.
Not a lot of followers.
Yeah. What's your Twitter?
So it's Dr Ahmed Roble.
Dr Ahmed Roble.
Yeah. Okay. I'm on Instagram as well. So DM me. Anyone wants advice? Cool. I'm more than happy to help.
Brilliant. Thank you very much for coming in. I hope everyone listening benefited today.
Yeah.
Take home message, detection.
Definitely.
Yeah, early detection. Definitely. So that's it. Yeah. Thank you very much for tuning in. I hope you all enjoy the rest of your week.
Thanks, Dr.
Take care. See you later.